Hello, everyone. My name is Caitlin Jones, and I'm a medical student at UT Southwestern Medical School. I am currently doing research under two UT Southwestern plastic surgeons, Dr. Nicholas Haddock and Dr. Sumit Tiosha. They do a ton in plastic surgery, but one of their main surgeries they do is post-mastectomy breast reconstruction. So my focus, I am an MD and PH student, so I love talking about insurance and looking at the impacts of different types of health insurance. So what my project is concerning is basically looking at the impact of a health insurance contract timing on breast reconstruction completion options. And I'll talk a little bit more about what I mean by that health insurance contract timing. So to start, let's understand the problem. A lot of people don't understand what health insurance looks like for a person that wants breast reconstruction after a mastectomy. So I'm going to talk a little bit about what that looks like. So back in 1998, there was an act called Women's Health and Cancer Rights Act of 1988. And this basically provided protection to women by ensuring that health insurance companies supply coverage to all aspects of post-mastectomy breast reconstruction. So as a result of this, those like economic hurdles that patients were constantly facing actually began to fall. And then these rates of breast reconstruction began to rise as women were finally able to afford, a breast reconstruction after their cancer care. So although this act did transform care to many patients that were wanting breast reconstruction, significant disparities to care remain. So that is one of my primary concerns is also with my MPH looking at what these disparities are. So I've linked a few here for you to go and look at if you were interested. So these campaigns came about trying to minimize these disparities that exist. And one of those was the Breast Cancer Patient Education Act of 2015. And this allowed patients to kind of understand their rights more as a patient and understand their options more, right? And breast reconstruction, there's so many different avenues you could go with having, autologous reconstruction, which is a flap, and there's multiple locations you can take a flap from, or, an implant-based surgery. So this can all be very complicated and overwhelming for a patient that has, being diagnosed with cancer and is having to battle their insurance and pricing and chemo and radiation on top of this reconstruction option. So this act was really helpful for patients to, finally get to understand their options as a patient. So looking at a timeline here, the cost of breast reconstruction can create substantial hurdles for patients and families. So breast reconstruction is usually not like a one and done kind of surgery. Typically a patient, presents with breast cancer, you have a mastectomy or like an oncologic surgery where they take part of the breast away. You can do different types of breast reconstruction, as I was talking about, and autologous reconstruction is where they take a flap from your body and make a breast mound out of that. But even still, you might have to do some revisions, some fat grafting. You might want to do nipple reconstruction at the end to regain some kind of appearance there. Patients might want to lift. The patients might want a bilateral mastectomy and reconstruction. And there's tons of options. So my whole point here is that this can be a super long journey, multiple revisions, operating room visits. So as patients are battling, paying for the breast cancer care, they also have to battle paying for the, breast cancer reconstruction. So the reason a calendar year is important is because it's really crucial to receive optimal care within this efficient and cost-reducing time frame so that patients are able to maximize their yearly health insurance plan benefits. So the purpose of my study is to analyze the impact of the health insurance cycle. So the health insurance cycle is either like calendar based or non-calendar based. So when I say calendar based, I mean things like, say you have Blue Cross Blue Shield that resets annually on January 1st versus maybe you have Aetna that resets September 1st. So calendar based resets at the end of the calendar year. Non-calendar based does not reset at the end of the calendar year. So that could be something that's like a public program, or it could be something like, as I said, Aetna that resets in September. So I'm going to talk a bit about my methods, my data collection, and my statistical analysis methods. So as far as data collection, the lab at Southwestern has utilizes what's called a REDCap database. So basically I went into REDCap and I filtered out patients that between 2014 and 2018 that had done post-mastectomy breast reconstruction by these two senior surgeons that I work with. So Dr. Nicholas Haddock and Dr. Sumit Tiosha. So they also share standardized surgical practices as well. So the data were collected on the insurance contract timing and the insurance payer during this time. And I got some of that information from the electronic health record I was able to incorporate into REDCap. So some of this information included like demographic factors, the timing of the reconstruction, so like when they start versus when they end, how many revisions they got, what type of reconstruction they got, the insurance payer status. Was it a private payer like Blue Cross? Was it private like Blue Cross or public like Medicare, Medicaid? And then their contract timing. So when did their health benefits reset? So that is how I categorized calendar-based versus non-calendar-based, was when their health benefits reset in their patient chart. So I'm going to talk about the results. I used a statistical software called Stata. You might be familiar with it. And then I just did significance at 0.05, of course. So in total, I had 514 patients in my study between those years of 2014 and 2018 that had post-mastectomy breast reconstruction. So a total of 136 patients were on non-calendar-based, and then 378 were on calendar-based insurance. Of those enrolled in a calendar-based, most were actually on a private health insurance plan, some were on a public plan, and then it was slightly skewed for non-calendar-based. Some were on private, whereas most were on public. So CBI versus non-CBI. So we're looking at the time of the year that their deductible reset. So something super important that I found was that individuals on a calendar-based program were more likely than those on a non-calendar-based program to have their last surgery closer to the end of the year. So what that means and why that's important is because people on a calendar-based insurance feel that they're like constrained within that yearly, an annual deductible reset timeline. So they're more likely to utilize those November and December months to have like their last revisions or their nipple reconstruction, because once they go past that December 31st timeline, what do you know? Their deductible resets, and now a simple fat grafting procedure costs a lot more than it would have if they would have used it at the end of their calendar year. I also found that patients on CBI were less likely to receive autologous reconstructions than individuals on NCBI. The reason I think that's important is because, as I said, they might feel they have to complete reconstruction within their one single health insurance plan benefit year. So autologous reconstruction often has like multiple revisions and stages of revisions, complications, whatnot. So they may elect to do something with less complications, less revisionary surgery, such as implant-based reconstruction, whereas non-calendar-based patients may not feel as constrained by that cost. So this is a super important graph. I love it because they're so easy to read and they have such like a grand impact. So this study actually came about when I was sitting in a research meeting, I think in like November or December, and my mentors were saying, man, we are just booked in clinic. Like everyone's wanting in right now. And we got to thinking about, why that was. And it was true that patients were trying to get in their last revisions, their nipple reconstruction, their fat grafting before the end of the calendar year, and their deductible, went ahead and reset, and their out-of-pocket max reset and all that good stuff. So on the graph on the left, it looks at the month of the last reconstructive surgery for those on a calendar-based insurance, whereas that on the right looks at non-calendar-based insurance, the month of last surgery. And you can see that on people with a calendar-based insurance, you can see just a huge spike there in December and November, where patients are trying to get into clinic to make sure that they don't have to pay a whole another yearly deductible for their revisions. Contrary, non-calendar-based insurance people may not feel that because it looks like there isn't a peak in November and December. All right, so next I looked at private versus public payer and found that individuals on a private insurance received more revisionary procedures and operating room visits than those on public insurance. And there's a lot of factors that may contribute to this, one of which is that the government may like reimburse less for public payers. And so maybe in general, like they just don't get as many revisions because they are reimbursed less. In addition, people on public insurance may have a harder time like getting off of work in order to come in and get those revisions, and also have a harder time like taking off a period of time for their recovery as well. I also found that individuals on private insurance are more likely than those on public insurance to have their last surgery closer to the end of the calendar year. The only reasoning I could put behind that is there is a higher cost associated with private insurance of their deductible, their copay, their out-of-pocket max. So maybe, those patients feel more, constrained by that, cost that would be associated with going over the end of the year. So talking about completion of revisions. So basically, patients were judged to be completed of all revisions by these two senior surgeons if they had completed the breast mound and were found to have symmetry, and basically they didn't need any more revisions to have their symmetry in their breast mound. So among individuals enrolled in a calendar-based insurance, people that were complete actually started their reconstructive journey earlier in the year and finished later in the year than people that did not complete all revisions. So, I think the reason this is important, with Breast Cancer Awareness Month being in October, sometimes people can go in, get their mammogram, find out the horrible diagnosis that they have breast cancer. Lo and behold, they have their mastectomy November, and then their calendar year deductible resets right there. So basically what this is saying is if patients start earlier in the calendar year, say they get their mastectomy in January, they get their DIEP flap, immediately, or, immediate delayed. So within the next few months, get their revisions, they're actually more likely to be complete, right? Because by the end of the year, their health insurance plan benefits haven't expired, and they're able to finish all those like minute revisions and asymmetry procedures and tucks and everything that a patient might need to feel like they have, symmetry in their breasts. So what are the implications of this study? So for a patient, this study suggests the importance of cost discussions and reconstructive decision-making tailored with the patient's health insurance in mind. So with the act I was talking about in 2015 that helped patients understand, their rights and what kind of reconstructive options they had, it's really important that, providers and patients discuss these things, and they're aware of the impact of one's health insurance on their ability to complete breast reconstruction and work with that. So if a patient is on a calendar year health insurance, maybe have those discussions about making sure the patient comes in so they're not, bombarded in clinic in November and December, and they have a higher likelihood of getting into clinic and being scheduled ahead of time. So they don't, call in November and then have their hopes let down when they're not able to get in. As well for a provider, the study predicts the increased demand of revisionary surgeries towards the end of the year. I remember sitting in that meeting, and it's stressful as a physician, I'm sure, to have all these patients that are wanting to get in, because cost is such a huge factor for patients that are paying for breast cancer care and reconstructive care. And then lastly, for payers, so like the insurance payer here, I know some insurance companies have adopted models of elasticity to account for like the difference in demand throughout the year. So this study really allows those companies to adopt these models of elasticity to predict the cost of reconstruction closer to the end of the calendar year. And lastly, it's important to ensure that breast reconstruction is equally available to every woman that's wishing to have reconstruction, independent of the time of year of their breast cancer diagnosis and mastectomy. Some of the grander implications of the study is for policymakers to selectively reduce these out-of-pocket costs for revisions and fat grafting and things that may seem simple to others, but for a woman with breast cancer can be very important. So that is like the big overarching theme of my study. Thank you all so much for listening in today. I know this was a lengthy little discussion, but as I said before, I am an MD, MPH dual degree student. So health insurance is something I am so passionate about, and something that I really want to always, have conversations about with my patients when I do become a physician. So again, thank you so much for coming and showing interest in my project. I really appreciate it. Feel free to send me any questions you may have. Thank you.